Uterovaginal prolapse, or prolapse for short, refers to the descent of the uterus and/or vaginal walls due to weakness in the pelvic floor. So we've got different types of prolapses, but to understand what these are, we first need to have a look at the normal pelvic anatomy. So here we've got the bladder, the uterus, and the vagina, with its anterior wall and posterior wall, the colon and rectum, and this space over here between the uterus and rectum is called the pouch of Douglas, or the recto-uterine space. Great, so now let's look at the different types of prolapses. So first up, we've got a cystocele. This refers to the descent of the bladder, as you can see over here, pushing on the anterior vaginal wall. Next, we've got a urethrocoele, which is a prolapse of the ureter. This typically occurs in combination with a cystocele and referred to as a cystourethrocoele, which also pushes on the anterior vaginal wall. Then we've got a rectocoele, which refers to the descent of the rectum, pushing on the posterior vaginal wall. An enterocoele refers to the descent of the small bowel through the pouch of Douglas, still poking its way through the posterior vaginal wall. Now, a uterine prolapse refers to the downward descent of the uterus into the vagina, while a vaginal vault prolapse occurs in women with no uterus after hysterectomy, where the vault starts to descend. Now, depending on which aspect of the vagina is involved in our prolapse, we can group them up. So the cystocele and urethrocoele, which both push on the anterior vaginal wall, can be grouped as anterior vaginal wall prolapses. The rectocoele and enterocoele, which push on the posterior vaginal wall, can be grouped as posterior vaginal wall prolapses, and a uterine prolapse and vaginal vault prolapse, which push the vagina from above, are referred to as apical prolapses. This grouping is important on examination to decipher which prolapse type we are dealing with. Great. So moving on, we're going to have a look at why a prolapse takes place and some risk factors. So we need to take a look at our anatomy and what holds these pelvic organs in place. So we've got three forms of support, starting off with the bony structure, made of the ilium, ischium, pubic bones, sacrum, and coccyx. Then we've got the muscles. The levator ani muscle over here forms a sling that holds the pelvic organs in place. Then we've got ligaments and fascia holding structures upwards. So we've got the uterosacral ligaments, the pubocervical ligament and fascia, the transverse cervical ligaments, also called the cardinal ligaments, and the perineal body and perineal membrane. So essentially, anything which weakens this system can result in a prolapse. Now let's take a look at some causes and risk factors. First up is pregnancy. 50% of Paris women will develop a prolapse at some point, versus 2% of nulliparous women. The risk is greater in those who have had a vaginal delivery. Next up, we've got age. So the longer we walk around on this earth in our upright position, gravity takes its toll, resulting in weakening of the pelvic floor. Increased age is also directly related to menopause and low estrogen levels, which is associated with a loss of collagen and a further weakening of the support system. Obesity also causes an increased risk due to raised intra-abdominal pressure, resulting in chronic increased pressure on the pelvic floor. Similarly, chronic constipation also causes chronic increased pressure. Another risk factor is smoking, which is associated with a chronic cough, again putting pressure on the pelvic floor. Same can be said for patients with COPD. Women with connective tissue disorders, such as Ehlers-Danlos or Marfan's, are also at risk of developing a prolapse, as well as women with a family history. Now, what do these women present with? Most patients typically present with a vaginal lump or a sensation of heaviness, as if something is going down, especially towards the end of the day. Sometimes it is relieved when lying down. Some patients will present with back pain because of the effect of the stretched muscles and ligaments downwards, pulling on the back muscles. Others may present with dyspareunia, that is painful sex. With a prolapse obstructing the vaginal introitus, this can make sex uncomfortable. Next, we have urinary symptoms, such as urinary incontinence, frequency, and incomplete emptying, possibly resulting in recurrent urinary infections. This is of course typical with a cystocele or urethrocoele, as the downward displacement of the bladder prevents its appropriate function. Similarly, a rectocele or enterocele can present with bowel symptoms, such as chronic constipation and incomplete emptying, sometimes requiring manual evacuation of stools. Not fun. Moving on, so in a clinic, once we have a suspicion of prolapse from the history, the next step is to examine these patients by performing a vaginal examination. Multiple grading systems are available to quantify the severity and type of prolapse. The POP-Q system is the best and allows for standardized staging. Although it might seem daunting with all the acronyms, it's fairly straightforward. If you would like a video on the POP-Q system, leave a comment down below. The more simple staging system is the baden-walker halfway system, which defines a prolapse in relation to the hymen. This image is looking at a prolapsed uterus. Grade 0 referring to no prolapse. Grade 1, the prolapse has descended halfway to the hymen. Grade 2, the prolapse has descended to the hymen. Grade 3, the prolapse has descended beyond the hymen. And Grade 4 refers to complete eversion of the uterus, also known as prosidentia. This image over here gives you an idea of what a prosidentia looks like on examination. These patients may present with bleeding and ulceration of the prolapse. Lastly, let's discuss treatment. This is a brief overview. In reality, there's a lot of detail when it comes to treatment, as treatment options depend on the type of prolapse, symptoms, age, and quality of life of the patient, etc. But broadly speaking, conservative measures include pelvic floor muscle training, which strengthens levator muscles to support the pelvic organs. Vaginal estrogens can be used in those women who suffer from vaginal atrophy. Vaginal pessaries are a common conservative treatment option. They help to keep things in place essentially. The most common is the ring pessary, but then we have all of these different types of pessaries too. Many surgical options exist, ranging from a hysterectomy to anterior vaginal wall repair, posterior vaginal wall repair, etc. I hope you found this video helpful. Like and subscribe.